Hi, this is Dr. Raghu Kasari. Thanks for watching the video. I hope this module is helpful for you. We'll get started with the critical congenital heart disease and congenital heart disease in pediatrics. So we'll go ahead and get started. Okay, so I'd like to start with a story. A full-term baby who was born in the nursery did very well, went home. Um, in the office, baby did fine on day 5, was feeding well, gaining weight well, pulse ox saturation in the arm was good. On the 11th day, baby had some rapid breathing and some slow feeding was seen elsewhere, and the baby did not appear very sick and was sent home, thinking that it was due to respiratory infection. A day later, baby was seen in another medical clinic, was noted to have more rapid breathing. Baby had testing done with B nitritic peptide, which was very high, and was transferred to emergency room and stabilized, given prostaglandins, and got surgery done, and the baby is doing well. When I looked at this, it touched my heart, and I felt, can we do anything to diagnose these babies at an earlier stage and stabilize them and send them to a tertiary center? Um, I thought of creating a module to help healthcare providers um, to keep a critical congenital heart disease as a possibility when they see any baby in the first few weeks of life. Um, my objectives of the talk: prevalence of congenital heart disease, screening for critical congenital heart disease, pulse ox screening, and identifying um, s- early signs of congestive heart failure. Uh, mission: increased awareness, screening of all babies under 3 weeks in any healthcare facility or healthcare encounters, early diagnosis, stabilization, um, and transfer to a tertiary center. Um, Congenital heart disease affects 1% of the babies. Approximately 8 babies are born with congenital heart disease out of 100 live, 1,000 live births. Slightly more than half of them have ventricular septal defect. Uh, 2 to 3 out of 1,000 have critical congenital heart disease. Um, in one of the statistics, I noticed that 40% of the babies who have critical congenital heart disease leave the hospital, um, uh, which is astounding. Um, Increased awareness can help to reduce uh, the morbidity and mortality. Uh, Cause is unknown in most cases. 15% of the congenital heart disease associated with genetic conditions. Um, I was surprised to see some important modifiable risk factors which are quite commonly seen. Maternal diabetes, obesity, and maternal smoking are risk factors for congenital heart disease. Uh, you may pause the video now. This module has 11 quiz questions. The quiz questions are uh, at the website medresource.org /CCHD. So you may access those by clicking the right panel here, or you may just type it in. Uh, once you're done with those 6 questions, please come back and continue with the video. And then again later, you'll have another opportunity to finish the last five questions. Uh, uh, this is one of the questions you saw uh, at the web link. So let's see. Which of the following is an important feature of congestive heart failure in an infant? Uh, you know, uh, s- Commonly we think of pedal edema or excess weight gain. Actually, those are not very common in infants. Diaphoresis during feeding, that is an important symptom. When you're watching this video, if you want a faster pace, if you click the control button in the right hand lower corner of the screen, you can adjust the speed to 1.5 or 2 so that you can save some time. Um, you can also make it higher resolution if you choose to do so. Uh, which of the following is not an important feature of critical congenital heart disease under 1 month of age? Uh, In fact, contrary to the popular belief, heart murmur is not very important. Poor perfusion, low pulse ox saturation, feeble femoral pulse, those are important features. Uh, which of the following is not a feature of congestive heart failure? Uh, um, Excess weight gain is not a feature. In fact, failure to thrive or weight loss is one of the features of congestive heart failure. Tachycardia, tachypnea, liver enlargement. Just examining the baby in the abdomen, starting in the right lower quadrant and ascending gradually to feel for the liver and measure the liver uh, span. Um, if it is significantly increased, that would suggest that the baby may have congestive heart failure. Which of the following is not an important sign? We talked about it just now, which is tachypnea, tachycardia, and edema of the feet. Edema of the feet is not an important feature. Um, Ductal dependent lesion usually manifests in the following age group: in the first 2 weeks of age, 2 to 4 weeks, 1 to 2 months, 2 to 6 months. So typically it is in the first 1 to 2 weeks. Um, Fairly large VSD usually manifests with symptoms in the following age group: first, birth to 1 week, 1 to 2 weeks, 1 to 2 months, and 3 to 4 months. Typically, it is seen between 1 to 2 months because babies have high right sided pressures. VSD being a left to right shunt, um, there is not as much flow because the right pressure is also high, uh, like the left sided, there is not much flow. But with time, or 1 to 2 months, the right sided pressure gradually drops, then the left right shunt uh, is more prominent, leading to congestive heart failure. Uh, Critical congenital heart disease versus congestive heart failure. Congestive heart failure typically is present between 1 to 2 months of age. It is emergence but not as critical. CCHD typically between 1 to 2 weeks. In some conditions, even before that, there is rapid deterioration with critical congenital heart disease. I made a mnemonic to remember. Um, when you see a baby um, with a potential CCHD. Um, the mnemonic is CCHD, FTT. FTT, you may remember as like failure to thrive. CCHD would be C for central cyanosis or pulse ox saturation being low. I have put N in the parenthesis. N stands for nurse. P stands for provider, could be a physician or a physician extender. Uh, HX for history. Uh, the second item in this is central perfusion, poor perfusion. Typically, if you just check the perfusion or the chest wall, see the refill time. If it is greater than 3 to 4 seconds, then you think that there is a poor perfusion. Heart murmur is not very important. Diaphoresis or difficulty in feeding. Uh, F stands for femoral pulse, and T for tachypnea, T for tachycardia. People who work at OSF St. Francis Hospital may remember the same as OSF St. Francis Hospital. Uh, mm, O for oxygen desaturation, S for skin perfusion, F for femoral pulse, S for failure to thrive, T for tachypnea, feeding is slow, and heart murmur. Ductal dependent lesion uh, means um, the when the ductus is open, the baby can thrive, does okay, but once the ductus closes, uh, which is a natural phenomenon, there is rapid deterioration. So I'll come to those conditions a little later with the diagrams. Ductal dependent lesion can be broadly classified as left-sided lesion and the right-sided lesions. The right-sided lesion like decreased pulmonary flow. Left-sided would be critical aortic stenosis or coarctation of aorta. Uh, Babies who have decreased pulmonary flow, they will have minimal symptoms in the beginning, and in the first 24 to 72 hours, they typically manifest with worsening cyanosis, hyperoxia test. Um, uh, when performed, doesn't show a good response. Hyperoxia test would be giving 100% of oxygen to the baby and checking the arterial blood gas. Uh, if the PaO2 uh, uh, doesn't increase beyond 150 to 200, then you think that there could be possibility of uh, cyanotic congenital heart disease. However, echocardiogram is the gold standard test. However, in rural areas, access to echocardiogram in infants um, is very difficult. Um, Decreased pulmonary flow as seen on the chest X-ray. Uh, Coming to decreased systemic flow present between 1 to 2 weeks, um, cardiogenic, they manifest with cardiogenic shock, poor perfusion, diaphoresis, tachypnea, tachycardia, poor femoral pulse, cardiomegaly on an X-ray, hepatomegaly, metabolic acidosis is often seen. A critical congenital heart disease with decreased systemic flow. Um, that would be uh, the left-sided obstruction. Will start at the ventricle, so hypoplastic left ventricle. The next higher up, critical aortic stenosis. The next higher up, coarctation of aorta. Just to look at this diagram, which will help us to understand the left-sided lesions well. Uh, the left ventricle is hypoplastic, so which causes like obstruction physiology, aortic stenosis, or coarctation of aorta. Say if there is a coarctation of aorta and there is ductus in this part, which is labeled as DA, um, The blood which comes out here can go to the pulmonary artery. However, when the ductus closes, the blood flow um, to the distal aorta is compromised. Um, simil- uh, Similarly, the right side obstruction, like pulmonary atresia, can cause right-sided lesions or right-sided obstruction. A coarctation of aorta, you can notice the proximal aorta is little bit dilated, but there is significant narrowing here, which is the coarctation. This is the ductus. The ductus is providing the blue blood or the deoxygenated blood, which mixes with the pink blood and providing a partially oxygenated blood to the distal part. The babies can do okay even with this. However, when the ductus closes, the real problem starts. Because the distal part has partially deoxygenated blood, the pulse ox will be lower in the legs compared to the right arm, um, which we'll be discussing later. This is the hypoplastic left heart. Hypoplastic left heart, you can see how small the left ventricle is. So even the ascending aorta is pretty small. This is hypoplastic left ventricle again. CCHD with decreased pulmonary flow. Let us start with tricuspid atresia. So the blood getting into the right ventricle is decreased. Then critical pulmonary stenosis or even pulmonary atresia. A tetralogy of fellow is a combination of features. The most important is, of course, pulmonary stenosis or pulmonary atresia, then right ventricular hypertrophy, ventricular septal defect, and overriding aorta. But the severity of symptoms in tetralogy of fellow depends on the severity of pulmonary obstruction. Uh, Critical pulmonary atresia, you can notice here how narrow the pulmonary artery is, almost no blood can enter there. This is the ductus. The blood from there is a VSD. The blue blood get mixes with the pink blood and goes to the aorta, and through the ductus, retrograde flow into the pulmonary artery, going supplying the lungs. Um, as an emergency surgery, they may do BT shunt. Uh, so that provides a communication between the pulmonary artery and the right subclavian artery. This pulmonary atresia with the intact ventricular septum. This is tricuspid atresia. You can notice that the blood from the right atrium does not come to the right ventricle, and in fact, there is often a ASD through which the blood goes to the other side. Uh, DTGA would be aorta arising from the right ventricle and the pulmonary artery arising from the left ventricle. So basically, the aorta and the ventricle are switched. So actually, the surgery they do is the arterial switch operation. Double outlet right ventricle. Um, Both the pulmonary artery and the aorta um, originates from the right ventricle, and there is a big VSD. Um, it is important to see the baby 1 week after the discharge from the hospital. When you look at the child, which of the following is an emergency? Cyanosis. When I meant cyanosis, it is central cyanosis, poor perfusion. Both are very important. And tachypnea alone, it's hard to predict congenital heart is just by tachypnea alone. But if there is combination of heart murmur with poor weight gain with tachypnea, then it becomes an emergency. Tachypnea alone can be due to fever, or it could be respiratory infection, and so many other things. Murmur alone is not an emergency. When a patient has these symptoms, we also want to make sure there are no other non-cardiac causes for the problem. Uh, Congenital heart disease in infants um, uh, manifests with liver enlargement, diaphoresis with feeding, shortness of breath with exertion, respiratory distress, grunting, tachypnea, tachycardia, slow weight gain. Um, in pediatrics, modified RAS heart failure criteria is used to assess the severity of congestive heart failure. This is similar to New York classification for adult heart disease. Um, Dr. Raz was my mentor during my residency. I was lucky to have him as my mentor. Um, Class 1 is asymptomatic. Class 2 is mild tachypnea or diaphoresis with feeding in infants, uh, dyspnea on exertion in older children. Class 3 would be marked tachypnea or diaphoresis with feeding, and marked dyspnea on exertion, prolonged feeding time, or growth failure. Class 4 would be symptoms such as tachycardia, retractions, grunting, or diaphoresis even at rest. The key thing is class 1, no symptoms, 1, mild symptoms with exertion, and class 3 would be marked symptoms with exertion, 4 would be symptoms at rest. Ventricular septal defect, so the typical left to right shunt, so there is more blood flow going into the pulmonary artery, which causes pulmonary congestion. So the blood returns, and so there is extra blood volume on the heart, causing congestive heart failure. This is the chest X-ray of an infant with congestive heart failure. You can notice the significant cardiomegaly. Signs and symptoms at 1 to 2 months: tachypnea, often with diaphoresis during feeds, poor weight gain, and heart failure is if the baby is thriving well, heart failure is unlikely. Decreased femoral pulse mm, is often present. Central cyanosis can be present in late stages of congestive heart failure. Heart murmur in isolation is not very important. Workup includes CBC, CMP, uh, which can show evidence of metabolic acidosis, blood culture to rule out infection, CRP to rule out an infection, arterial blood gas can give us an idea about oxygenation, and brain natriuretic peptide. Recently, it's being called as B-type natriuretic peptide. That can be very helpful when you do not have facility for echocardiogram, especially when you suspect critical congenital heart disease or plain congestive heart failure. Chest X-ray can look for the shape and size of the heart and pulmonary markings, whether they are prominent or decreased. In right-sided obstructive lesions like pulmonary atresia, there is decreased pulmonary markings. In left to right shunt, there is increased pulmonary markings. EKG, echocardiogram is gold standard. Stabilization, routine resuscitation steps. Um, uh, Pediatric advanced life support measures should be taken. Initiate emergency transfer to a tertiary center. Prostaglandin E1 is a life-saving drug. It can keep the ductus open. However, it has a couple of side effects which are very important. Diuretics and digoxin in congestive heart failure. Uh, PGE1 keeps the ductus open, uh, and they can cause a little bit of fever, but do not use any NSAIDs to control the fever because it can nullify some of the action of PGE1. The important side effects include apnea and hypotension. You may have to intubate and start mechanical ventilation. Hypotension, you may have to give more fluids. Sometimes you may have to use dopamine or dobutamine. Patient education is very important. When the baby goes home, it's important to let them know that they need to come to the emergency room or to the physician's office, uh, or call the healthcare provider if the baby has any bluish discoloration in the lips, um, uh, if the baby has shortness of breath during feeding or excessive sweating. uh, they may have to call 911 if it is an emergency. Uh, and also routine instructions like baby needs checkup if there is any fever, or refuses to feed, or increased jaundice, and so on. This is a flow chart provided by American Academy of Pediatrics. This is uh, screening which needs to be done before the discharge from the hospital. Uh, Typically screened between 24 to 48 hours of age, um, and um, screening may result with mm, low pulse ox or intermediate pulse ox or a good pulse ox. Pulse ox saturation is checked both preductal, which would be right hand, and postductal would be one of the feet. If both the pulse ox saturations are greater than 95 or equal to 95, and the difference is equal to or less than 3, is fine, which is a negative screen, so that's normal. If the pulse ox saturation is less than 90%, that is a positive screen, so that's abnormal. If the pulse ox saturation is between 90 to 94, or if the difference is greater than 3%, then it falls in intermediate category. Then you have to repeat the screen in 1 hour. If you come to the same conclusion, then you have to wait for 1 more hour and then repeat it. If it is the same, then you consider as a positive screen which needs stabilization. Um, I have take home message for three different setups. One would be discharge from the newborn nursery. Screen every baby for critical congenital heart disease prior to discharge. Um, we have been doing this for a few years now, but now it is state mandated in many of the states. Um, Pulse ox saturation to be done in right hand and 1/4, uh, and follow up in the physician's office or the physician extender's office at 7 days of age, um, so that we can screen them for critical congenital heart disease. Uh, if a child is seen in a walk-in clinic or emergency room setting, remember um, to screen all babies less than 3 weeks with the 60-second screening, which I talked to you about, like looking for. We talked about CCHD, FTT, that mnemonic. Basically, looking for femoral pulse, tachycardia, tachypnea, central cyanosis, or pulse ox saturation, heart murmur, and diaphoresis, decreased feeding, and slow weight gain or failure to thrive. Uh, when the baby's screening by the nurse would include pulse ox saturation in the right hand and foot, and if it is abnormal, the nurse needs to verbally alert the abnormal vital signs to the provider so that they can act on it in a busy setup. Sometimes it can be overlooked. Uh, if a physician assistant or a nurse practitioner sees a baby under 3 months of age, um, I recommend to talk to the supervising physician, or run it by them, um, or ask them to evaluate the baby to make sure they're not missing something. Pulse ox screening. Uh, in the primary care physician's office, when they see them under 3 weeks of age, but typically we have to do it at 1 week for sure, but up to 3 weeks is a good idea because some of the critical congenital heart disease can manifest at 1.5 to 2 weeks or so. Um, Nurses to verbally communicate again the abnormal vital signs and perform the CCHD FTT screening under 3 weeks of age. Um, Again, you may pause the video here and go to medresource.org/CCHD to finish the next 5 questions. And then you can come back here and finish. And it should not be, it shouldn't take too long to finish the rest of the video. Um, I'll pause for a few seconds so that you can pause and move on to the website. So let me go to the next slide now. Uh, Baby's pulse ox saturation is 96%, and the difference in the pulse ox is in the right hand to right foot is 4%. This 4% falls in between category, and 96 falls in a good category. So because it's in between, um, whether you call this as a negative referral or a positive referral. This is a positive referral because they did it on 3 occasions. Um, if it was first time, you do it in an hour later. An hour later, positive would be need urgent stabilization. Here the pulse ox saturation 94% or 90% in the foot. So this an hour later it is 95 in the right hand and 92 in the foot. The difference is 3%, and also there is 95%, so it becomes a negative screen. So we should be okay unless there are other symptoms. A pulse ox saturation of 92% in the right hand and foot on 3 different occasions at 1 hour interval. So it becomes a positive screen and would need urgent referral. During well child checkup, noticing one of the following in a baby, in the absence of sepsis warrants immediate referral: um, tachypnea, poor perfusion, and central cyanosis. This is a except question. So central cyanosis, you have to do referral, and poor perfusion. Tachypnea, because there are other causes which we discussed before. Um, Baby turned blue. The color change is mostly clinically significant uh, if it is in the perioral area, or fingers, toes, or tongue and buccal mucosa. If it is the buccal mucosa, then it becomes a central cyanosis. Uh, okay, so let's see. Appreciate spending time here to participate in this module. Uh, I hope it was helpful. Feel free to contact me if you have any questions. Thank you and have a great day. Bye bye.